doctors, a very good evening and welcome to this today's CME session sponsored by KIMS Sunshine Hospital. So today's our guest lecture is from Vijay Kumar Reddy sir, a senior interventional cardiologist with the experience of over 20 years in treatment of heart related elements, and he has performed nearly more than 10,000 coronary interventions, both simple and complex, and around 50,000 diagnostic procedures. And coming to his MBBS, he did his MBBS from Cardiology Medical College in the year 1976 to 1982. Later, he did his MD General Medicine from Cardiology Medical College in the year 1984 to 1987. Later, he did his DM Cardiology from Gandhi Medical College in the year 1998 to 2000. Coming to his work experience, he worked as Assistant Professor in Medicine at Cardiology Medical College, later as Consultant Cardiologist at NIMS Hospital, and followed by Interventional Cardiologist at MedCity Hospital, and later in Sunshine Hospital from the year 2014 to till date. He did vast research and training. He has attended international conferences in Beijing, Tokyo, Nagoya, and he has trained many DNB and post-DM students all over India in interventional cardiology. His field of interests are coronary interventions, structural interventions, device closures, peripheral interventions, and balloon valvuloplasty. And most importantly, he is from our area, and most of us know the sir for the many years. So with this brief introduction, I welcome our guest to deliver his speech today.
Topic was diabetic dyslipidemia here inside. The basic idea and objective of choosing this topic is diabetes is not one man's disease. It affects from head to toe all the diseases. So the basic idea of choosing is to, and for the next 15 minutes I am going to talk, interact, discuss with you about the diabetic dyslipidemia and its implications and resilience. But remember this, diabetes is not the end. It is the beginning of a new way of living. It's a disease of high blood sugar and lipids. 2 out of 3 people with diabetes, they die either from heart disease or from stroke. That is the implication of the diabetes. Don't think it's a disease of a high blood sugar. The deadly 90% of the diabetics, they are having dyslipidemia. So the combination is pretty strong and pretty high. And so what is diabetic dyslipidemia? Diabetic dyslipidemia is characterized by high triglycerides, high HDL, low HDL, high LDL, especially small dense LDL. I will explain later what is small dense LDL and the increased ApoB. So all these are the typical features of a diabetic dyslipidemia. So just before going into the actual subject, I will briefly interact about the lipids. Lipid is a hydrophobic. It is not transported to the blood because it's a hydrophilic. It is covered by a layer of phospholipids and a layer of lipoproteins. These phospholipids and lipoproteins are responsible for making lipids from hydrophobic to hydrophilic, so that it is transported in the circulation. That's the basic structure. LDL is the most atherogenic particle. Whenever there are some risk factors like smoking, diabetes, it undergoes oxidation. It has become oxidized LDL. So the oxidized LDL is the one that is responsible for the athermatous clots. Number 2, there are a lot of trials, BCC trial, Ethiopia's advanced PAD trial, origin trials. In all these trials, there is a strict glycemic control. fasting blood sugar is under control, postprandial blood sugar is under control, HbA1c is under control. But the fact is that it has not shown any benefit. So strict glycemic control will not show any cardiovascular benefit. The answer is very big no. So glycemic control alone is not useful for the prevention of atherosclerosis. There is one landmark trial that is published in 2005. It's basically a primary prevention trial. In the trial, they selected patients with diabetes with normal LDL. They are given atorvastatin 10 milligrams, and the duration of trial was 5 years. And statins in diabetes with normal LDL were decreased by 37% and insulin substitute by 48%. There's a phenomenal decrease of either cardiovascular disease and stroke by giving simple statin patients of diabetes with normal LDLs. Until 2005, all diabetics, no diabetics are receiving statins. From 2005, it is mandatory for all diabetics between 40 to 75% age, they should receive moderate intensity. So this third style changed the treatment paradigm of diabetes with dyslipidemia. Now, Indian dyslipidemia and Western dyslipidemia. What is the difference? We are having more of lipoprotein. Our triglycerides are high. Our HDL is low. So that is the difference when compared to Western population and Indian population. Why diabetics disorders? Why diabetics are more to get dyslipidemia? Problem is insulin resistant. There are two things. One is that adipose tissue, liver. These are the two important organs that are responsible for lipid metabolism. Insulin will inhibit the hormone lipoprotein lipase. So because of insulin resistance, there is a degradation of triglycerides and there is a formation of free fatty acids. So these free fatty acids are responsible for the so many changes of increased triglycerides, increased ApoB and increased VLDL. All this, they are responsible for the triad of dyslipidemia that is characterized by high triglycerides, high LDL and low HDL. This is the ST. Just a brief word about lipoprotein A. It's highly atherogenic particles. In India, 25% of all of us, they are having high lipoprotein A. And every person, every adult should undergo once in a lifetime the test for lipoprotein A. Why? Because it is genetically is responsible for any premature cardiovascular disease and it can also cause aortic stenosis. That is the reason why every person should undergo lipoprotein A once in a lifetime. A small word about what is small dense LDL. We Indians having not normal LDL, we are having small dense LDL. What is the difference between small dense LDL and normal LDL? Small dense LDL, it undergoes two things. One, it can easily oxidized. The oxidized LDL is the responsible factor for atherosclerosis. It can easily get oxidized. Number two, it can get easily glycated. This glycated LDL, it is not taken by the LDL receptors. So because of easy oxidation and more glycation, this is very, very atherogenic when compared to normal LDL. That's about models. And one thing, we are not concentrating on non-HDL. Please remember, in diabetic patients, non-HDL cholesterol is as good and as important as LDL levels. So you should use that. You should test that. Why Indians we are having more of dyslipidemia? What are the reasons? Number one, we eat more of a rice, we don't exercise, and we are this ratio also is more, is high abdominal fat, and we are not active, and then our diet is more of a carbohydrates, less of a polyunsaturated, and there are some genetic variants, ApoC3 and APO genes, they are common in India. That's the reason why when Western diabetics, Indian diabetics, you were having more of a this dyslipidemia. These are the factors responsible for the high incidence of dyslipidemia in Indians. Despite using statins in diabetes, are you sure that you are not able to get coronary artery disease? Absolute answer is absolutely no. Still there is some residual risk. What are the reasons for that? Reasons for that, there is a triglyceride rich lipoproteins, inflammation, lipoprotein A, and diabetes is an inflammatory state. So because of these reasons, despite controlling LDL with statins, still we are more prone to get coronary artery disease. That is called residual risk. Remnant cholesterol is also one of the factors that is responsible. It is a total cholesterol minus LDL plus HDL is called remnant cholesterol. And there are two targets. In the Lipid Association of India, it is got separate guidelines. We are having LDL is the primary target, non-HDL is the co-primary, ApoB secondary target. Whereas in international guidelines, only they targeted LDL and non-HDL as a secondary target. But Lipid Association gives this non-HDL is as important as LDL. See, only less than 18% with diabetes they achieve goals. That is goals of less than 7, BP less than LDL. It's a very sad fact. So all the goals of type 2 diabetes, ABC goals, it's a very sad fact. With the Indian diabetic females, 97.8% they are having diabetes. They are having dyslipidemia. Males, so almost 9 out of 10. If the patient is diabetic, he is having definitely dyslipidemia. See, in our practice, how many diabetes patients are receiving statin? The fact is very, very sad. There is one study from CME value, so only 6 to 16% of Indian diabetics they are receiving statins. The fact is very, very, very sad and pathetic. The fact is that the concept of diabetes is only glucose-centric. It's a very, very wrong. It should be cardio, metabolic centric. We should control the sugar, control the lipids, control the body weight. All things will finally give some cardiovascular benefit. This is insulin resistance is the main factor in case of diabetes. You can call all this malformation, hypertension, obesity, finally leads to atherosclerosis. So this is the clinical attack. You should give high intensity statins. If it is not getting good response, and extremely, if the patient is statin intolerant, give bempedoic acid, still not receiving, go for PCSK9 inhibitors. So we are challenging. So why there is a big challenge in diabetes? Already said 9 out of 10 are having dyslipidemia. Why we are prone for dyslipidemia? I explained because we are taking more of a carbohydrate, we are not doing exercise, we are having abdominal fat, all those things. Then in diabetes, there are abnormalities, LDL, non-HDL, triglycerides, ApoB, low HDL. Reduction of LDL is beneficial. Reduction of triglycerides, beneficial. Reduction of non-HDL, beneficial. Increasing good cholesterol HDL, is it beneficial? Answer is absolutely no. Most of our patients come, sir, my good HDL is very low. What should I do? Shall I increase the tablets? There is one trial called AIM high trial. They given this drug niacin to increase the HDLs. There is no cardiovascular benefits. So don't worry about increasing HDL, concentrate on LDL, concentrate on non-HDL, concentrate on triglycerides. In case of dyslipidemia is the single most important CV factor for myocardial function. There is one study called Interheart study. There they mentioned lipids are responsible for 50% of the first MIs in this study. All the are only 7-8%. So dyslipidemia, which is very prominent in diabetes, is responsible for most of the cardiovascular events. So in dyslipidemia patients with the diabetes, CV risk is increased by 3 to 4 times. So all the trials show we should reduce triglycerides to 150 milligrams to have some benefits. Hypertriglyceridemia is an independent risk factor in case of diabetes. For every increase of triglycerides of 89, the CV risk is increased by 32% in men and 76%. So in case of diabetes with dyslipidemia, high triglyceride, it is an independent cardiovascular risk factors. And this factor is more important, especially in women. So all international bodies, whether it is European Society of Cardiology, American Heart Association, American College of Clinical Cardiology, American Diabetes, they say reduce triglycerides to 150. That's very essential. So optimal control of glucose. There are two types of complications in diabetes, microvascular complications and macrovascular. Optimal glycemic control leads to there is a 24% risk reduction for microvascular disease. So non-HDL cholesterol versus LDL. So non-HDL cholesterol is a strong predictor of CV risk than LDL cholesterol, especially in women. Please concentrate on this non-HDL cholesterol. It's more important than LDL, especially in women. There is a drug, bempedoic acid. We are adding a lot of drugs for LDL cholesterol reduction, statins, SMB, bempedoic acid. The advantage of bempedoic acid, most of the patients with statins, they got myalgias. But myotoxicity is not seen with bempedoic acid. That's the advantage of this thing. But one thing, while giving bempedoic acid, please check for uric acid. And bempedoic acid, when you give for starting intolerant patient, there is a 13% relative risk of MACE. It is a class 1 recommendation for patients who are not tolerating statins. PCSK9, there are wonderful drugs. They reduce LDL cholesterol by 60%. This is the only one class of drug which will reduce 60% of the LDL reductions. It can also reduce lipoproteinuria and no adverse glycemic effects. PCSK9 inhibitors, they block the PCSK9 and increases the availability of LDL receptors. So if the patient cannot tolerate statins, what is the other alternative? You can give a combination of low dose of statin with XLD, which is also responsible for the decrease in the LDL cholesterol. Omega-3 fatty acids, they are very much useful to reduce the triglycerides. There are two evidence. There are two trials. One is strength, and this trial shows there is a benefit in the reduction of this. There is A, B, C. So in case of Indian diabetic patient, what should be the normal LDL? It should be less than 70. The Indian diabetic heart disease, what is the LDL level? It should be less than 55. Indian diabetes patient, heart disease, high risk, less than 30 is the LDL goal. That is the recommendation of the Lipid Association of India. So normal patients, normal diabetic, no heart disease, your LDL should be less than 70. So what is the feature of lipid lowering? You should lower it early. You should treat it aggressively and use combination therapy wherever it is necessary if the patient is intolerant. There are class of drugs, all this can reduce statins 50%, PCSK9 reduces to 60%. These are all the statin lowering drugs. This is about the action of inclusive and augmentations. There are 10 commandments in diabetic dyslipidemia. Diabetic dyslipidemia are already mentioned. It is highly prevalent. 98% of the female and 95% of the male having this commandment number 1. Diabetes hypertension dyslipidemia is called deadly trial. So there is a 1% of LDL reduction. The CV risk is by 1%. Dyslipidemia trial is specific to diabetes. That means high triglycerides, low HDL, and high LDL. It is very typical to diabetes. Non-HDL is a better indication of LDL in diabetes. Please remember this point. LDL is the primary target, non-HDLC is the important. If the patient is statin intolerant, there are alternative ways of like bempedoic acid. Non-statinopathies can reduce only CV risk, but not all-cause mortality. So, icosapentaenoic acid is medication show CV reduction. And finally, ladies and gentlemen, and August to conclude, diabetic dyslipidemia is characterized by high triglycerides, LDL, low HDL. LDL, lower is the better, earlier is the better. Insulin resistance is the root cause of all this evil. Statins are mainstay of treatment, aggressive LDL. Lifestyle modification is very essential. If you do exercise daily, the cardiovascular events are decreased by 32%. Beyond the LDL, there is still a residual risk because we have to target other atherogenic particles. The fact is, improving HDL will not show any cardiovascular benefits. It is proven in AIM high trial. Please remember, strict glycemic control alone is not beneficial. It is the dyslipidemia management is the rule but not exception. Finally, thank you very much for your patient attendance and kind attention. I would like to answer for any question. Sir, statin treatment like that in sir. No, we have to maintain, you should treat it early, aggressively and where you should use even the patient reach the LDL targets also. You should use the statins. So many patients, I got some of the patients from United States, they are not, though they are having diabetes, they are not receiving. I'm finding out with them, receiving long tests. But the fact is, please remember, the patient is having diabetes between 40 to 75 years. Don't worry about LDL cholesterol. Please give moderate intensity statins lifelong, because it's proved in that landmark CARDS trial, there is a significant reduction of 27% of cardiovascular events and 48% reduction in stroke. There is a pretty high value. Please and make it a habit. Diabetes, in addition to this is the statin, this is standard of therapy. Diabetes is disease of sugar, not only it is the disease of sugar in the patient. That is the objective of my lecture today.
75 years, irrespective of their LDL levels. So now I request our senior IMA doctor and ex-state IMA president Sri Reddy sir to kindly come over and hand over the memento and honor our guest lecture today. A senior person from our town, Sri Reddy garu has come today here. So he wanted, he has been campaigning, he is before telling what's the reason. He is the recipient of both liver organization. He has been doing activities for the past few years. So this year he wanted our IMA to come along with him. So he wanted a requester. So for that he has planned. He is willing to plan a activity like walk to conduct a rally for organ donation, awareness of organ donation. So on this occasion I welcome Sri Ramesh Reddy garu to share his ideas regarding that event.
నాకు 2002 సంవత్సరానికి లివర్ ప్రాబ్లం వచ్చింది. ఇండియాలో ఎక్కడ కూడా మొత్తం కార్పొరేట్ హాస్పిటల్ అంతా తిరగడం జరిగింది. లాస్ట్కు హైదరాబాద్లో గ్లోబల్ హాస్పిటల్లో కొత్తగా పెట్టినారు. అప్పుడు ఆడ పోయి జాయిన్ కమ్మన్నారు. అప్పుడు పోయి మాట్లాడితే వాళ్ళు యాక్సెప్ట్ చేసినారు. 2003 మార్చి 11వ తారీఖు నాకు లివర్ దొరికింది. వరంగల్లో రామప్ప గుడి పూజారి కూతురు స్వప్న అనే అమ్మాయి బ్రెయిన్ డెత్ అయితే ఆ అమ్మాయి ఇచ్చింది. అప్పుడు గవర్నమెంట్ రూల్ ఏముందంటే లివర్ కానీ ఏదైనా అవయవం దానం చేస్తే సస్పెన్స్లో ఎవరికి చెప్పకూడదు అనేది గవర్నమెంట్ రూల్. తర్వాత మళ్ళీ మేము కనుక్కొని 2007లో పొద్దుటూరు వచ్చి మన IMAలోనే వారికి సన్మానం చేయడం కూడా జరిగింది. వారు మీకు ఏదైనా డబ్బు ఇస్తాం తీసుకుంటే మాకు వద్దు, మేము తీసుకోము, మాకు హ్యాపీగా ఉంటే చాలు, మా కూతురు చూసుకున్నట్టు అని చెప్పడం జరిగింది. అప్పటి నుంచి నేను రమేష్ రెడ్డి చారిటబుల్ ట్రస్ట్ అని పెట్టి అన్ని కార్యక్రమాలు పొద్దుటూరులో చాలా కార్యక్రమాలు ఇదే IMAలో మెడికల్ క్యాంపులు దాదాపు 9 కార్యక్రమాలు చేసినాను. అంతేకాకుండా 2014లో పొద్దుటూరు నుంచి తిరుమల వరకు పాదయాత్ర చేసినాను ఈ అవేర్నెస్ కోసం. ప్రతి స్కూలు కాలేజీ అన్ని దానిలో కూడా చెప్పుకుంటూ పోయినాము. రెండో పాదయాత్ర వచ్చేసి విజయవాడ నుంచి కనకదుర్గమ్మ గుడి వరకు చేసినాము. అది కూడా 29 రోజులు పట్టింది. ఆ కార్యక్రమం కూడా ఇదే అన్ని ఊళ్ళల్లో కాలేజీలు స్కూల్స్ అన్ని చోట్ల కూడా అవేర్నెస్ కోసం చెప్పడం, అప్లికేషన్స్ ఫిలప్ చేయడం. అలాగే ప్రతి సంవత్సరం ఏదో కార్యక్రమం చేస్తూనే ఉన్నాము. లాస్ట్ ఇయర్ 25వ సంవత్సరంలో కూడా పొద్దుటూరులో 3K 5K అని కూడా పెట్టడం జరిగింది. దాదాపు 7-8 వేల మంది దాంట్లో పాల్గొనడం కూడా జరిగింది. ఈ సంవత్సరం ఏమనుకున్నామంటే మొట్టమొదట అవయవదానం అవగాహన రావాలంటే డాక్టర్స్ ముందుకు వచ్చి మేము అవయవదానం చేస్తామనేది పబ్లిక్లోకి రావాలి. అది వచ్చినప్పుడు ఏమవుతుందంటే కనుక పబ్లిక్లో ఒక ఇది ఏర్పడతారు. ఒరే డాక్టర్లే ఇస్తున్నారు, మనం ఎందుకు ఇవ్వకూడదు? యాక్చువల్గా మీకు అందరికీ తెలుసు, బ్రెయిన్ డెత్ అయితేనే అవయవదానం తీసుకుంటారు, లేకుంటే లేదు. అది కూడా ఏమి మన జీవనదానికి అప్లికేషన్ ఇచ్చినా కూడా ఆ రోజు పేరెంట్స్ విల్లింగ్ అయితేనే తీసుకుంటారు, లేకుంటే లేదు. కాబట్టి పొద్దుటూరులో ఈ కార్యక్రమం ఒకటి పెట్టాలని చెప్పి మన పెద్దలు కలిసినాను. త్యాగరారెడ్డి నన్ను, నాగేశ్వర రెడ్డి సార్ కొందరు కలిసినాను. అందరూ కూడా చాలా బాగుంటుంది ఈ కార్యక్రమం పెట్టమన్నారు. మార్చి 8వ తారీఖు పెడితే బాగుంటుందని చెప్పి మన ప్రెసిడెంట్ సెక్రటరీతో కూడా మాట్లాడడం జరిగింది. కాబట్టి ప్రతి ఒక్కరు కూడా ఇందులో పాల్గొని మనం జీవనదానికి అవయవదానం చేస్తామని చెప్పి అప్లికేషన్స్ ఫిల్అప్ చేసి ఇవ్వడము. అందులో భాగంగా జస్ట్ 1 పర్లాంగో 2 పర్లాంగో బై వాక్ చేయడము. తర్వాత కార్యక్రమము మార్నింగ్ పెట్టాలా ఈవినింగ్ పెట్టాలా అనేది మన పెద్దలు నిర్ణయిస్తారు. వాళ్ళు చెప్పిన దాని ప్రకారము మార్చి 8వ తారీఖు ఈ ప్రోగ్రాం పెట్టాలనుకున్నాము. మీ అందరి సహకారం కోసం ఇక్కడ నేను వచ్చినాను.
I am sure that most of us will join the event, so we will plan along with we will discuss and how we should proceed. So with this coming to the next week, so our president, as our tradition, wanted to give a gift to those listeners who have participated from the first till the end. So now we will select one from the female and one from the male. Common, both. He doesn't want to discriminate between both males and females. Dr. Sandhya.